All right, now we're moving on into the final topics of psychiatry, and one of the first few things are your eating disorders. Now, the eating disorders, even when I was brand new to this, they were not very confusing. There really should not be much overlap or confusion in picking one answer over the other. In CK, it's a little more complex. In step one, they mentioned it in a little more linear manner. So the initial breakdown is anorexia nervosa and bulimia nervosa, and then you have your binge eating disorder. Now, the names kind of give away what's happening. So, for example, anorexia nervosa is someone who is anorexic. So, right away, you can immediately understand that your patient has to have a low BMI. They have to be very much underweight, not just low weight, but underweight. And other things that come along with being an anorexic individual will also follow, such as menstrual irregularities, lack of muscular strength, fatigue, anemia, stuff like that. So, intense fear of weight gain, overvaluation of thinness, and body image distortion, leading to caloric restriction and severe weight loss, resulting in inappropriately low body weight. Now, notice what the words in this sentence are, right? So, they're saying that there's a body image distortion and that there's a overvaluation of thinness. Now, if your patient in your question talks about these two things a lot, right, you may start thinking that this may be some type of body dysmorphic disorder or one of the other things like some of the things that fall under gender dysphoria. Let me see where they mention body dysmorphic stuff. No, not those. Not any of that either. I'm not even sure where it actually does get mentioned, to be honest. Body dysmorphia. Actually, that I'm not even sure if it's a step one topic, to be honest. It's supposed to be. It's probably here somewhere. But the point is that the way they mention these questions, right? And when you talk about patients who are anorexic or bulimic, they'll often mention things that may make you think it's not just about weight gain or weight loss, that it's more about that they think they look ugly or something like that, and one of those other psychiatric body dysmorphia and those related topics. It's not one of those. So you want to focus, and this is true for every psych question, you really want to focus on the root issue. Why do they feel they're ugly? Is it because they want to not be a female and be a male now? Or do they feel like a certain part of their body does actually just look ugly? Then at that point, it might even be body dysmorphic disorder. Or is it just that they think that being just super skinny is the only beautiful, right? And anything other than being super skinny is ugly. Then that would be anorexia nervosa. So the true root cause, right? And every time you look at any this is always a list of vocabulary, right? So every time you look at any one of these diagnostic terms, you want to know and figure out the root cause of that diagnostic term. So bulimia nervosa, anorexia nervosa, what's the root term or root cause of anorexia nervosa? Fear of weight gain, nothing else. The fear of weight gain should be the key thing that the question is focusing on, right? And then they can try to confuse you with OCD and OCPD with these things as well, where a person might be like very picky on what they want to eat simply because they think it'll make them fat. Then you're gonna get a little confused on what's happening. So then there's a couple things you can do to figure out, how to not get confused. And in anorexia nervosa, the thing is going to be the inappropriately low body weight, right? So now in here, under anorexia nervosa, you have three subtypes or three relevant issues. There's the binge eating and purging type of anorexia nervosa. This one has recurring purging behaviors like laxative and diuretic use or self-induced vomiting or binge eating over the last 3 months. Okay, this is extremely common. A lot of people do this. Remember how this starts. A lot of this often starts with a person who has a goal to lose weight, but they're also addicted to food. Like they just can't help it. When they see food or they take food, they just eat all of it and they can't portion it controllably. So then later on they're upset about it. Over a period of time, they realize that this is not really working out and they've been trying to lose weight for all these months, maybe even a year, and haven't lost shit. So then they fall into this routine where they think, and this is a very fantasy type belief, that if I eat food and then I take a laxative, I'm just going to shit it all out, so I'm not going to gain weight. That's not how laxatives work, though, right? You're still eating food, you're still absorbing everything, and then you're making fecal matter And once you're done making fecal matter after absorbing everything you ate, then yes, the laxative will help poop it all out. So then, that's not the point. That's not what the person wanted to do. But not everyone has that total understanding, right? It's almost, as you can see from the chapter we're in, it's almost a little psychotic. Diuretic abuse is also very common. You might see a family history of the patient having a mom or dad or someone in the house who uses diuretics. Diuretic abuse does cause weight loss because you lose a lot of water loss, right? So the patient will maybe take a pill from the parent every day and just eat it, and they'll start losing water weight. They'll be urinating all the time. You'll be able to see that in their labs because whatever the diuretic is probably also for hypertension, so they'll be pretty hypotensive, and they may look very dehydrated. Those are some things you'll look for. And then, of course, the purging, self-induced vomiting, right? Really problematic thing. Of course, that leads to acid-base disorders, and you want to make sure you understand how. So we'll talk about that when we get there. The other one is binge eating. So this is going to be somebody who fasts for a certain period of time because they're trying to lose weight, and up to that part is okay. But then when they open their fast, the days that they're not fasting, they'll significantly overeat, which of course undoes the point of the fast. It breaks the reasoning there. The restricting type is another one. Primary disorder behaviors including dieting, fasting, and over-exercising. No recurrent purging behaviors of binge eating over the last 3 months. So they're really just restricting themselves heavily to lose weight. This isn't really that psychotic, right? Because they're not doing anything that problematic. As long as they're healthy, then it's not psychotic. As soon as the restricting type eventually puts them into the anorexic subgroup, then they are. So where this matters is what is the weight of the person doing this, right? The person doing this restricting behavior, if they're actually overweight, then it makes some sense for them to be doing it, right? They're restricting how much they eat. They're trying to eat less. Of course, cutting down your calorie intake and calorie restriction is the #1 way of losing weight. And then they're exercising a lot because they probably weren't exercising much before and they really want to see results. All of that is fine. But if the person doing this is not overweight, then it's not fine. So if someone is like a BMI of 18, 19, and they're doing all of this, then it's anorexia nervosa. That's pathological. They can die, right? And this has to be happening over the last 3 months. All right, these are all 3 month. And the last thing here is refeeding syndrome, which I've mentioned before is something relevant to what happens even back in Hitler's time when he had all those concentration camps and all the people were being held and they were hungry. When America and other countries came to save them, the food that was brought to them actually caused a lot of them to die because of cardiac complications, seizures, and rhabdomyolysis. Right? People that are malnourished who suddenly have an increase in caloric intake will have sudden release of insulin that they were never releasing because they weren't eating. Insulin causes a potassium shift, right? So you're gonna get that hypokalemia, and then off of that potassium shift, you're supposed to be able to release insulin, but unfortunately, this potassium shift is so sudden, and so severe, so strong, because you have to understand that their insulin receptors are dying to be turned on, right? Their insulin receptors are hypersensitized because they haven't received any insulin in so long, or haven't had to release any insulin in so long because they haven't eaten in so long. That this all kicks into overdrive and they get hypomagnesemic and hypophosphatemic, and it all leads to problems. Remember that magnesium is also related to PTH secretion, and PTH is related to calcium. So then of course all of this comes together, right? The electrolyte imbalances are a huge deal on CK. There's an entire section about it where they go in depth, right? So it's very important. In renal, you're going to see that. Next group is your bulimia nervosa. Now here, BMI is not going to be anorexic. Right? You don't need to worry about whether it's normal or overweight. Point is, it's not going to be anorexic. So the BMI is not going to be very, very low here. Right? Recurrent episodes of binge eating with compensatory purging behaviors at least weekly or over the last 3 months. Right? So the point of eat EAT, the word has three letters. So that's how I memorized that it was 3 months for all of these time period. But generally speaking, you're probably never really going to get a question where it's happening for less than 3 months. If it is, it's probably not one of these things. Okay, so then you start thinking it's one of the other answer choices. Although I will be honest, I have seen questions where the answer was anorexia nervosa, but the question never mentioned more than 3 months. So you don't necessarily need a time period to be mentioned for you to pick anorexia nervosa or bulimia nervosa as an answer choice. That being said, in bulimia nervosa, this is kind of similar to the binge eating purging type anorexia nervosa. So you see, the only way to differentiate the two will be the BMI. And these patients, they do kind of sort of end up balancing it out. Now, because they have this, in this group, there's more purging behavior of vomiting than there is of laxative use. And vomiting will actually make sure you don't gain weight, because at that point you ate food and then vomited it back out before you were able to absorb everything. That's different from laxatives, where you absorbed everything and then the laxative just helped you poop more of your feces. But once you've made fecal matter, that means you're done absorbing everything. So that's different. Things you can look for in these patients: you can see for parotid gland hypertrophy on their face, enamel erosion because of all the acid they're vomiting out, electrolyte disturbances like hypokalemia and hypochloremia, metabolic alkalosis, right? These are all happening because you're losing your HCl in vomit. Dorsal hand calluses like these, because their teeth are scratching their hand when they're trying to put their hand in their mouth to try to induce vomiting. So you get this Russell sign. That's your dorsal hand callus. Treatment for all of these doesn't really require medications, right? All of these patients initially really just need a lot of psychotherapy and nutritional rehabilitation, right? And then if things are getting worse, or if they're becoming very anxious or depressed or something along those lines, you could think of SSRIs, right? Same thing here too. First thing you do is psychotherapy and nutritional rehab. Then you can consider SSRIs. Never bupropion. Bupropion, we've mentioned a couple times before. Great antidepressant for patients who want to quit smoking, but it lowers the seizure threshold. And if you're doing things like anorexia and bulimia nervosa, where your electrolyte imbalances are pretty off whack and you're not eating well, then getting a seizure is even easier in these patients. Right. Last thing here is BED, BED, binge eating disorder. This is different from binge eating with compensatory purging behaviors. What these patients do is binge eat without the purging behaviors, right? So they just binge eat, but they never purge. Recurrent episodes of binge eating without purging at least weekly over the last 3 months. High risk of diabetes, most common eating disorder in adults, especially in America. Right? It's just they can't stop eating. They love eating. Oftentimes it's related to some kind of emotional thing, like they're depressed so they can't stop eating. But most times you want to look for someone who is just eating, because you don't want to be, you have to figure out what diagnosis do we have the most bullet points filled out for. If the patient is depressed, then you start looking for MDD things. If they meet the criteria for MDD, then they don't have binge eating disorder, they're just depressed, right? So you want to look for someone who's just eating because they're just eating. They just have this habit of maybe every Friday night eating like 5 burgers, a bunch of soda, stuff like that. Every Saturday having cake, and the whole fucking cake, not just like a slice. So then when you see those kinds of things occurring, of course there's a high risk of diabetes there, because they're going to become fat, right? In this case scenario, although not required for the diagnosis, in this case scenario, binge eating disorder BMI is probably going to be on the higher end, right? So on USMLE, higher end is over 30. Okay, normal is anything ranging from like 24 to 30, 22 to 30, depending on the age of the person, gender of the person, how athletic they are. And anything under 20 is pretty safe to assume it's a low BMI, right? So those are the USMLE type of questions right there. And you can see again, psychotherapy and nutritional rehab are going to be key things. And then you can try SSRIs, which is a single paintbrush for everything. So coming back to here, first thing they talk about anorexia nervosa, and then we have a question on it, where a lot of people messed up and thought it was hypothyroid. Risk factors include female gender, low self-esteem, high socioeconomic status, associated with OCD, MDD, anxiety, and careers, hobbies such as modeling, gymnastics, ballet, and running. Patients are often perfectionists and high achieving. They have a distorted body image and fear of gaining weight, which is the main thing. Fear of gaining weight is the root thing you're looking for, right? People can avoid foods because they're picky. People can avoid foods because they're OCD. People can avoid foods simply because they have body dysmorphic disorder, all kinds of things. But you want to know the reason for their anorexia is because they fear gaining weight. divided into two subtypes: restrictive or binge eating purging, which we looked at just now. Restrictive is restriction on food intake for weight loss, and binge eating purging type is eating and then compensating the food you ate with excessive exercise, vomiting, or laxative slash diuretic use. The binge eating purging type is severely unhealthy. Restrictive type is a pretty good idea for losing weight, but not if the patient is already a BMI of 19. Then it's pathological. Signs and symptoms: cachexia, right? They look like they're dying, like cancerous dying. BMI under 18.5. Lanugo, which is baby hair. So here I had a note, right? Associated with low bone density, often irreversible. Amenorrhea due to loss of pulsatile GnRH secretion, and anemia because they're just not eating, so no iron, right? May also see lanugo, which is fine, soft hair that is normally found on the fetus or infant, baby hair basically. In anorexic patients, lanugo tries to help keep the body warm when there is not sufficient fat. Okay, so that's something you can see: really, really little baby hairs, furry baby hair all over them, and that's because they're anorexic and they need to make little hairs to kind of recover, maintain heat. Okay. You can also see, of course, the other signs of just not really having enough food intake, and a lot of these symptoms can oftentimes look like hypothyroid, right? Like cold intolerance, bradycardia, not really having menstrual cycles, right? So that's why people fall for this mistake here. Measure height and weight, check BMI, check CBC, electrolytes, and endocrine levels. So you're going to check for hormone levels of things, right? So you're going to check for TSH, and do an ECG because, of course, they can get seizures from lack of food intake. Perform a psych evaluation to screen patients for comorbid conditions like MDD and other anxiety disorders. And the treatment and complications are going to be in this table here, but we'll look at bulimia first before we look at the table. So bulimia nervosa is an eating disorder characterized by recurrent episodes of binge eating and compensatory purging behaviors, vomiting, laxative, diuretic abuse, excessive exercise. More common in women, associated with low self-esteem, mood disorders, and OCD. Patients often have a long history of other comorbid psych conditions like anxiety and depression, and are concerned about their behaviors, so they know some things of matter. Dental enamel erosion, enlarged parotid glands, scars on the dorsal hand surfaces called the Russell sign from induced vomiting, and BMI of more than 18.5, basically not anorexic BMI, are key things to look for here. I wrote here patients from GIT stuff. Patients may have a history of Mallory-Weiss tears due to self-induced vomiting. Excessive vomiting causes multiple metabolic derangements. So remember, the Mallory-Weiss tear was a linear tear in the esophagus from pressure differences because you induce so much pressure with the vomiting method, right, with the fingers in the mouth, at the back of your mouth. So that's something from GIT that you want to make sure you get a chance to revise. So if we actually go back and look at it really quickly, we can see right here Mallory-Weiss, right? And the two L's are to remind you of longitudinal or linear lacerations of the gastroesophageal junction confined to the mucosa and submucosa due to severe vomiting. Can often present with hematemesis, usually found in alcoholics and bulimics. Right, so something really interesting that can be mentioned in a question to kind of hint at the bulimic aspect. Excessive vomiting causes multiple metabolic derangements. When you vomit, loss of HCl and potassium in the vomit results in hypokalemic, hypochloremic, metabolic alkalosis. The dehydration and volume contraction activates the renin-angiotensin-aldosterone system, causing secondary hyperaldosteronism, and further worsens the metabolic derangements by increasing renal hydrogen and potassium excretion in exchange for sodium and subsequent water retention. Peripheral edema can then follow. So again, all of these things and what you're seeing here are things you can definitely get tested on. You always want to go back and revise this little thing from step 1 when we were learning about hyperaldosteronism and hypoaldosteronism. So for hypoaldosteronism, I made up this thing, right? That if you don't have aldosterone, you're going to lose sodium and you're going to keep potassium and hydrogen. So in our patient, the opposite is happening. But let's look at this first. So if you don't have aldosterone, you lose sodium and you keep potassium and hydrogen. If you're keeping hydrogen, then you have to throw away bicarb, right? That's obvious. You can't keep both of them, they'll combine. So if you're keeping the acid, you throw away the alkaline. Losing the bicarb means you're keeping chloride, because in your kidney, in the PCT, you have a bicarb chloride exchanger. So if you're exchanging, you have to throw away bicarb and retain chloride, right? So now you're going to have low sodium and low HCO3 and high KCl and H. So I made up this thing. I lose sodium bicarbonate and HCO3 and keep HKCl. Right? This is what basically happens when you don't have aldosterone. Now in our patient, because they're vomiting so much, you can imagine that's also a form of losing fluid, losing a lot of volume. So then they're going to release aldosterone to try to raise their blood pressure again, right? You can also understand that bulimic patients may be abusing diuretics, so then they have to try to turn on their renin-angiotensin-aldosterone system. In those patients, they can't, right? Especially if the diuretic is something like something that alters the renin-angiotensin-aldosterone system heavily, especially if they're also abusing or using ACE inhibitors, right? Otherwise, if they're just taking something like the water pill like furosemide, then yes, then the renin-angiotensin-aldosterone system will kick in, and you're going to have too much aldosterone. Now, when you have a lot of aldosterone, what does it do? It keeps sodium. So when you keep sodium, you always have to throw away potassium and H+. You can't keep all the positive ions, right? So you keep sodium, then you lose potassium and H+. This leads to metabolic alkalosis because you lost H+, right? Remember that if you're losing H+, you're going to retain bicarb, which is also going to add to the alkaline aspect. If you're going to keep alkaline bicarb, you're going to throw out chloride from the same PCT exchanger, and so on, right? So all of that is what you're thinking of for a patient who's going through repeated bouts of vomiting, right? So here is a pathogenesis of refeeding syndrome, which isn't really discussed too much here. But refeeding syndrome basically starts off like this. When you're starving, you're in a catabolic state. Catabolic state means that you're breaking down your own body's proteins and stuff in hopes of making things that'll help you survive, right? So back in step 1, we learned about the catabolic and catabolic and anabolic states of these hormones and how they work together, especially when we were looking at malonyl-CoA, right? So this is your little biochem moment right here, right? When you're starving, the first few things you run out of course, are all your sugar, all your glycogen, all the easy things to break down, right? Your protein, but your body sees fat as diamonds, and you never really want to sell diamonds. You want to save your diamonds. But if you don't have anything else and you're about to go homeless, then of course you end up selling your diamonds. So you're going to break the fat down. So the catabolic form kicks in, right? This is what performs in starvation, where you take all your fatty acids and you start breaking them into fatty acyl-CoAs, which then go through your carnitine shuttle, carnitine for carnage, and go into the mitochondria to help make ATP. So you see how you took your fat, broke all the fat down to make some ATP. Now, of course, starvation is a great way to try to lose weight, but not for an anorexic person, and not really starvation either, more so like long-term fasting with intermittent fasting, or just straight up massive calorie deficit. So you cut down like half of what you would normally eat. But all of that is not okay in a person who's anorexic, someone who doesn't even need to lose weight. Right? So now here, when you break down all your fat to make your ATP, the only way you can really make ATP is to first convert it all into acetyl-CoA, and then your acetyl-CoA can either give you some ketone bodies, or it can go into your TCA cycle. These patients are not releasing any insulin. They're not releasing any insulin because remember, if they were releasing insulin, insulin is an anabolic hormone. Release of insulin is a sign that you ate some cake, right? Release of insulin is a sign that you had something with carbs coming into your GIT. So at that point, that would be where you would make fatty acids, right? Fatty acid synthesis would occur. Citrate will be taken away from the TCA cycle and go through the citrate shuttle and sent out into your cytoplasm to basically make more fatty acids so that it can be stored in different parts of your body, right? That's the general concept of all of that right there. So you're seeing here, in a person who's starving, there's no insulin, so they're full-blown in catabolic state. Cortisol is going to come, try to help them manage their blood pressure and energy. Glucagon is going to be out in 24 hours. You're going to run out of all your glycogen reserves. And then you're going to start trying to make ketone bodies. Now, that you're going to run out of ketone bodies in muscle, and you're going to send all your ketone bodies to the brain, because your brain can only really use sugar and ketone bodies, nothing else. Your brain cannot really utilize any other forms of energy. So at that point, at that point, your muscles are going to suffer now, because if your muscles can't use ketone bodies, they're going to start breaking down. So now you have full-blown glycogenolysis, full-blown lipid cutting down, and full-blown protein breakdown. So your muscles going to start breaking, right? Depletion of fat, protein, vitamins, minerals, and intracellular electrolytes, assuming that this is happening over like a period of maybe multiple weeks, right? So by this point, you run out of everything. Your body is done everything it can to try to freaking have energy. Now, you start feeding the person, right? You just came to save this person, or you just rescued this person from maybe a cave they were stuck in, or something like that, wherever they were stuck where they couldn't eat. You rescue them, you give them food. Now you turn on the anabolic state. Now insulin is secreted. And remember, they haven't secreted insulin in, we'll say this happened in a month. They haven't secreted insulin in a whole month, right? So now all their insulin receptors are hypersensitive. Any insulin comes out, that insulin receptor is going to be turned on super quick. And there's also more insulin receptors than usual. Remember, we talked in our last episode of what happens with alcohol withdrawal and what happens to the two different types of receptors, the NMDA and the glutamate receptors and all that. So when you're not turning on a certain receptor, you make more copies of that receptor in hopes of being able to turn it on. So these patients who are starving are making more insulin receptors, so that anytime insulin finally comes to be, they're going to quickly save their own life, right? So as soon as they release any insulin, boom, you get full-blown glycogen synthesis, full-blown protein synthesis, and a huge intracellular uptake of phosphorus, potassium, magnesium, and thiamine. Now, that leads to problems, because now in your serum, you don't have any phosphorus, you don't have any potassium, you don't have any magnesium. You also end up running out of serum thiamine, because when you have sugar intake, vitamin B1 and sugar go together in helping everything work. So you run out of thiamine, which is going to kind of contribute to almost an alcoholic state of Wernicke-Korsakoff, kind of sort of similar thing. They're also going to have very high sodium and water retention because they don't have any potassium, so they can't do the sodium potassium ATPase exchange. Ultimately, you can see what's coming out. So you see the Wernicke encephalopathy because they ran out of thiamine. This is all happening without any alcohol intake. This is the only time you get Wernicke encephalopathy without alcohol intake, right? Seizures, congestive heart failure, and of course arrhythmias. Keep in mind all the electrolyte abnormalities and how they're related to things. And one of the critical ones I mentioned is magnesium. It was not such a big deal in step 1, but it is taught in step 1 endocrine, where they show you how magnesium actually alters parathyroid hormone physiology. So if we look at let's see, PTH. Right here. So if you look at how PTH works, when you have low serum calcium, then of course you're going to make PTH to raise serum calcium. That's the easiest, that's elementary. We all know this. If you have high phosphate, you're also going to make PTH. This is also pretty elementary because PTH is also called phosphate trashing hormone. Now, if you have low serum magnesium, then you will make PTH to raise calcium, right? But in our patients, they don't just have low serum magnesium. They have very low serum magnesium. And when that happens, you don't even make PTH. So that also leads to lack of calcium. Excuse me. And all of that is going to be really bad for them. Compare this now, jump over into renal to see how all this works. When you go to the renal anatomy and physiology and look at the different parts of the nephron and where these guys move around, then you get to see magnesium and calcium paracellular uptake right here in the thick ascending limb. Paracellular, right? This paracellular uptake has to occur only if this potential, this positive potential, is maintained by potassium leaving. None of this is going to work anymore because you just lost it all, right? Potassium can't do this anymore because potassium is too busy doing the potassium shift for insulin, right? Insulin causes a potassium shift into the cells. So now if all your potassium is inside your cells, how can it do any of this other stuff, right? This is happening in urine, in your kidney where you're making urine. So there's no potassium there to do this. All in all, it all comes together to totally mess the person up and they can die, right? So you had a person that was dying because they didn't have food. You gave them food and then they died. Right, so the only way to avoid this is when you give them that food, it has to be done in a rehabilitative manner, right? It's called nutritional rehab for a reason. It's the opposite of typical types of rehab. Like if you're an alcoholic and you need rehab, it usually involves cutting back on alcohol. You don't just take the alcohol away all of a sudden, right? Same thing here. You can't just give them food all of a sudden. It's slow increments of bringing them food, right? So you start off with maybe just bread, right? Maybe give them sugar and thiamine, right? It has to be a nutritional rehab. Nutrition means vitamins also. So you actually have to give them vitamins along with their food. Give them an iron supplement, give them B12, give them folate, give them thiamine, all these things that they obviously haven't been getting because they can't eat, right? So that's a key little thing to keep in mind. And then we have, of course, our table here teaching you more. So anorexia nervosa presents with persistent restriction of caloric intake, resulting in low body weight in a person who already had a low body weight. That's the key thing to keep in mind here, right? This is somebody who just has unreal fear of weight gain. Everyone has fear of weight gain, but to have a fear of weight gain when your BMI is under 20 is just unreal. An intense fear of gaining weight and a distorted body image. Patient perceives themselves as fat when they truly are not. All right, this is I'm not gonna say anything about that, but yeah, patients perceive themselves as fat. Patients are underweight, BMI under 18.5. Attitude towards illness. Well, patients are typically not distressed by their illnesses, and may thus be resistant to treatment. So basically, your question is going to tell you that this is a girl who was brought in by their parents. Right now, it's not going to be a 13 or 12-year-old girl. It's going to be like a 19 or 20-year-old girl, a girl that is totally capable of coming into a clinic by herself. But of course, she won't because she doesn't see a problem. Right. So this is what they mean when they tell you in a question that a girl or anyone is coming in with their parent. It's an indication of how they themselves probably didn't see that there's something wrong, right? The only reason for coming with your parents is if you're underage. At that point, it's different. Monitor calorie intake and weight gain. Hospitalize if necessary. Watch for refeeding syndrome. Psychotherapy to address maladaptive family dynamics. Antidepressants are not effective, okay? And treat comorbidities. Avoid bupropion because of risk for seizures, right? So all in all, the main answer choice you're going to be picking is psychotherapy, right? Like in this URL table. Cognitive behavioral therapy and nutritional rehabilitation, which nutritional rehab is a way of watching for refeeding syndrome, right? SSRIs for anorexia nervosa is not really a thing. You see here, the first one, we're looking at anorexia nervosa. You can't do anything. Olanzapine if no response to above, but that's about it. So the only answer choice you really need to know, right? This is going to be what I would say is basically a hard question that they can give you a patient with anorexia nervosa and they'll tell you that, you know, they tried a little bit of therapy, it didn't really work, blah, blah, blah. And then they'll be like, what's the next best step? And then they'll list out a bunch of antipsychotics, antidepressants, and all these mood stabilizer medications. It might even be J answer choices, right? A lot of 8 to 10 answer choices. They can do that to you because it doesn't matter how many answer choices they gave you. You need to know the correct answer choice before you even get to the answer choices, which would be olanzapine, the very, very powerful guy. Remember, olanzapine and clozapine are extremely powerful, atypical antipsychotics, right? An anorexia nervosa thing is somebody who is psychotic, not depressed, right? This is a person who sees themselves as something that they are not, right? So they are not fat, but they think they are, and that's a problem. But you don't really go for olanzapine if you haven't yet done the behavioral therapy and nutritional rehab. Bulimia nervosa is episodes of binge eating followed by compensatory behaviors like exercise, purging, or fasting, or laxative use, any of those things, at least once a week for more than 3 months. Patients don't have anorexic BMI, and patients are typically distressed about their symptoms and are thus easier to treat. These patients do want treatment, and most of them will come by themselves, not because a parent brought them. Right, so if you look back, and we'll probably see this in some of these questions, but when you do your questions, or if you look back at your questions, you'll see that the anorexia patient is the one brought by the mom because the girl just isn't eating, whereas the bulimia patient is one that comes in by themselves saying they're having trouble losing weight, because they keep eating and doing X, Y, and Z, or they come in because of symptoms related to their compensatory behaviors, right? Compensatory behaviors, remember, as we said, purging will cause alkalosis. Fasting will cause some level of alkalosis, but also just a lot of weakness. And excessive exercise can actually cause derangements in their endocrine secretions of things. So they'll come in, but they may not come in talking about their binge eating behavior. They'll come in telling you something they were doing, which is one of their compensatory behaviors, and now they're kind of weak or tired or sick or something. All right. So here you do psychotherapy plus antidepressants. They need help, they'll come ask you for help, you give them the help, right? Treat the comorbidities, and once again, just avoid bupropion and eating disorders, period. Right? So you see SSRIs like fluoxetine are a good answer choice for bulimia nervosa, right? The last thing that they don't have here, they don't really mention it in CK, is binge eating disorder, right? They don't mention it here under eating disorders. Binge eating disorders, recurrent episodes of binge eating without the compensatory vomiting, lack of control during eating. That's all it is. Very common thing. We all have a friend who just, they'll be like, oh no, I'm just gonna have a salad today. They sit down and they have the salad, and then they also ordered fries, and then later on you're seeing them with like another salad or maybe even half a burger someone left. They just can't control eating, and it's a psychological thing, because you remember your stomach is your second brain. Every time you eat, you stretch out your stomach. When you stretch out your stomach, the receptors fire signals telling you you're full, but those signals take a very long time to actually arrive to your brain. So by the time they arrive to your brain, you've already finished eating a shit ton of stuff. When the stomach unstretches, it sends out hunger signals, and that hunger signal is very hypnotic. It can literally control you into eating, and then once again you'll end up eating too much, because the number of hunger signals that were sent will add on, right? This is why you should fast, to get better control of your own eating impulses, right? You should have control over whether or not you need to eat, because unless you're anorexic or have some kind of eating disorder, that's a different scenario. Generally speaking, if you don't have an eating disorder, or if you have a slight eating disorder that isn't debilitating, then fasting is a good way to have mental strength as well as control over your urges to eat, and you're supposed to reward yourself with pleasure of knowing that you didn't eat, not reward yourself with a shit ton of food later on, right? Because then that would be binge eating. That's exactly what they do, right? They just have recurrent episodes of eating a lot, and oftentimes in between they're just eating normal amounts, and they think that if they binge eat one day and then other days they eat just normal amounts, that they won't gain weight. But of course they will, because they're eating normal amounts every day, and then there's that one day where they eat a lot more, and then normal, then a lot more. They never had a day where they didn't eat. Diabetic now, right? So these are some things you look for. Let's take a look at the questions here. So first question we have here: 16-year-old girl brought to the office by her mom due to constipation. She has had bowel movements twice a week for the past 2 months. No abdominal pain, but states her stomach is puffing up. Right. So notice how the question started. 16-year-old girl brought to the office by mom, right? And it's due to constipation. Very strange. If this 16-year-old girl has constipation, she could have came in by herself too, but 16 is also somewhat of an acceptable age to come with parents, so it makes sense. No abdominal pain, but states her stomach is puffing up. Her mom says the patient appears tired and wears multiple layers of clothing despite the warm weather. So the patient is cold. So they're cold, they have constipation. Medical history is significant for acne vulgaris, treated with topical retinoids. Her temperature is fine, blood pressure is very low, pulse is slow, respiratory rate is fine, BMI is 18, within the anorexic range, right? Under 18.5. On physical exam, the abdomen is scaphoid and non-tender with normal bowel sounds. What is the most likely diagnosis for this patient? Now, although her symptoms do heavily match some level of hypothyroidism, it is more plausible to suspect that she probably has anorexia nervosa, because it's a young girl. Why would a young girl out of nowhere randomly just have hypothyroidism? It just makes no sense, right? So you don't really want to suspect things that are not very much plausible. You want to suspect things that are more plausible, more likely, and work off of that, right? This young woman with constipation has bradycardia, borderline hypotension, and cold intolerance, along with the low BMI and distorted body image, saying her stomach is puffing up when it is scaphoid on exam. Now, you may not have caught that. You may not have known what it meant to have a scaphoid belly. But a scaphoid belly basically looks like, oh wait, you wouldn't be able to see that here. Let me copy. Look at what a scaphoid belly is, and if I show you the picture of scaphoid belly and then it completely rings a bell that that is definitely an anorexic person, then that was just a vocabulary problem there, right? This is a scaphoid belly, completely sucked in, completely empty. That's scaphoid. So now it's very obvious that she's anorexic, right? You can see her rib cage. When you can see the rib cage like that and this indentation, that's a scaphoid tummy. So her scaphoid tummy, even though she's saying it's puffing up, we didn't even care what she says, whether it's puffing up or whatever. The fact that she has a scaphoid belly is more than enough for you to think it's anorexia. GI complications of anorexia are extremely common. Decreased food intake and or electrolyte abnormalities usually result in slowed colonic transport time and constipation. Other typical GI complications include gastroparesis, GERD, and elevated liver function tests. In stable patients, first-line treatment involves nutritional rehab and psychotherapy. Medication doesn't really help here. If things get extremely bad, then as we said, you could try olanzapine. Right, so you see, UWorld tables are critical. This UWorld table has more things than this UWorld table does. This one only tells you medical complications, things you look for. And this list of medical complications is theoretically the same list of medical complications you would see for hypothyroid, but you have to have a better clinical suspicion of one thing over the other, just based off of likelihood and probability and statistics and all that data. This question here, this one is for, I believe, a bulimic patient. We'll see. 33-year-old woman comes to the office for help losing weight. So you see this patient's coming by themselves. She says, I'm really trying, but I haven't seen any results. She has been on restrictive diets that cut out various food groups, but gained 5 pounds in the past month. She feels defeated and says, nothing I try works. I end up feeling sorry for myself, and before I know it, I've eaten an entire cake. This is a real problem, and it's very unfortunate. It's a real issue. This is a real disorder. Of course it is, right? But what I'm trying to say is that this is really distressing, really distressing. Of course, this unfortunate difficulty in losing weight for this patient will also lead to anxiety and depression. Even though I feel disgusting afterward, I still do it a few times a week. She reports no difficulty with sleep, energy, or concentration. Mental status exam reveals an overweight woman wearing loose clothing. She is cooperative and has a reactive affect. Treatment options are discussed and she prefers to start meds. What is the most appropriate medication for her? So only 40% of people chose the correct thing. I don't know who these 20% of people were that chose bupropion, but I guess this is UWorld, so it's okay because maybe they were still learning or something. And 30% of people chose Orlistat, which is definitely a pretty good alternative medication for trying to lose weight, but not what she needs. So Orlistat is marketed as Ali, A-L-L-I. It's a pill that you eat that stops your body from absorbing lipids. It cannot absorb the oils and fats in your food. And basically what that leads to is you end up pooping out a lot of oily, it almost looks like steatorrhea at that point, and all of that just comes out. So you didn't absorb any of it. Not exactly what you want to give to someone like her, right? Because what she's doing is some level of binge eating, right? Now, if I give her something like Orlistat, which is very similar to a laxative, but even better because it's like causing her to lose all the fat she ate, I might actually be encouraging her to eat more, right? She's going to be like, wow, so now all the lipids I eat are going to get pooped out. So let me just go eat a shit ton of lipids, right? And that's going to suck because you're only pooping out the lipids, but you're still eating a shit ton of other stuff that doesn't get pooped out, and you're still going to gain weight, right? So Orlistat is not what you want to give, and you don't want to give weight loss therapy to a person with a eating disorder. If you actually fix their eating disorder, they'll probably normalize their weight, right? They'll normalize their weight. For example, if someone is anorexia nervosa, when you fix their eating disorder, you'll normalize their weight. And if someone's bulimia nervosa or they're really overweight bulimics, then again, you fix the eating disorder, it'll normalize their weights. Even if it doesn't normalize their weights, you need to first fix the eating disorder before you can actually try giving them treatment or therapy for their weight loss, right? So Orlistat, great medication for weight loss, but that's not what we need to fix here. The most appropriate thing for her with her binge eating bulimic activity is sertraline. Right? Her repeated episodes of excessive eating with loss of control are consistent with binge eating disorder. Mainstay of treatment is CBT, and pharmacotherapy includes SSRIs, lisdexamfetamine, and the antiepileptic topiramate. Topiramate is also an awesome medication. I've mentioned it many times. It's basically an antiepileptic, but it's also got this really interesting side effect that makes it really famous, which is weight loss, right? So mainstay of treatment is CBT, pharmacotherapy, SSRIs, lisdexamfetamine. Why did I spell it like that? Is it? Yeah, amphetamine. And topiramate. So again, farm questions are very difficult. You could see this as an answer choice, and you want to be able to pick it, right? Same thing for lisdexamfetamine. It's another one that they may, just a question where they don't mention any SSRIs at all, or it could be a man who's doing these things and he doesn't want to have the side effect profile of SSRIs, right? With the sexual deficits that occur. That being said, lisdexamfetamine may be the better answer choice for that person. Orlistat is an anti-obesity drug with no benefit in binge eating disorder either, right? Which is what this guy has, right? The last one, because he doesn't do anything bulimic per se, right? So it's just, this is a woman with binge eating disorder, because that's all she talked about. All she talked about was eating. She never talked about vomiting or anything like that. Be very keen on differentiating all three of these with the very specific thing you're looking for, right? Very specific thing you're looking for. Anorexia nervosa, fear of weight gain even though super skinny. Bulimia nervosa, eating and then go vomiting or exercising or doing something, anything to make up for the eating activity. And that other thing they're doing is the pathological thing. And then binge eating disorder, just eating. Can't help it. Trying to lose weight, but I keep eating anyway, right? That, which is this patient right here, right? So remember, a lot of patients, a lot of students here, you can't really entirely blame them. They messed up because they focused more on the first sentence, which was, I need help losing weight. But remember, you're the doctor, not her. So she says she needs help losing weight, but she needs help with her binge eating disorder first. All right. So that's how you fix that. Here is the list of other shit they can toss at you in a question to really confuse you, right? Constitutional symptoms, which are generally just all related to things about losing weight because you're not eating right? So that's what you're seeing here. Cardiac symptoms, once again, from refeeding syndrome, a lot of this can occur. GI symptoms, mainly the dental erosions from vomiting, delayed gastric emptying because they're not eating enough, abdominal pain, and then we also mentioned our Mallory-Weiss tears in patients who are doing the bulimic active vomiting. GU, amenorrhea, nephrolithiasis. You can get kidney stones, right, which may actually be the presenting reason the patient came in. A lot of patients, because most eating disorders are female patients, female patients may actually come in because they have amenorrhea, haven't had a period for 2 months, or they may have really bad flank pain on either side from a stone in their ureter, right? Nephrolithiasis. This happens because of dehydration as well as electrolyte abnormalities, and amenorrhea happens because of complete lack of energy, which messes up their usual hypothalamic pituitary ovarian axis, right? You're not going to waste energy bleeding for a menstrual cycle when you don't have any energy because you're not eating well, right? So those are some things to keep in mind, and that's all there is for the eating disorders. I'm going to take a quick break. I'll be back in like 30, no, not even, I'll be back in 10 minutes, and then we'll go on into our miscellaneous disorders and